Hello.
How are you?
Hey, hi, good to see you. Okay, I'm sorry. We had, as usual, it's a Murphy laws.
No problem.
You know, we had a bit of problem in lab, actually. There is a stock balloon in the left main. Yeah, okay, but now it's okay. Добрый день. Сейчас все хорошо, так что мы идем, мы можем сейчас начинать, да.
Окей. Ну, нас должны объявить еще пока, наверное.
Очень хорошо, да. А кто начнет, может, вы начнете тогда, да?
Да, Андрей, у меня уже целый текст подготовлен. Начну я и буду просить, чтобы заключительное слово и заключительное, чтобы сделали вы.
Хорошо. Ну, лекции тоже ваша будет первая, да?
Первая, да, вторая ваша, потом Семитка и потом госпожа Ратабильская.
Идеально, идеально, да.
Я думаю, мы можем уже занять слайды запустить, правильно?
А вот, да, я думаю, а вот как ребята скажут нам?
Давайте.
А есть прямая связь с ними?
Да, конечно, я думаю, надо сказать. Так.
Слушай,
Андрей, мы можем запустить слайды?
Да, вы организаторы.
Да, все, мы тогда запустим так, чтобы не терять времени.
Да, все готово.
Ну, вообще, мы можем уже начинать или еще кого-то мы ждем? Товарищи начальники.
Андрей, Георгий, Игорь.
На данный момент, добрый день, Давид Георгиевич, на данный момент 41 человек зашел.
Ну, я думаю, что мы не будем ждать, они присоединятся, кто при... Я думаю, что мы ровно в час должны начать.
Да, согласен.
Если нам, вы тогда дайте отмашку, когда нам начинать.
Андрей, тогда дашь отмашку? В принципе, можем прямо сейчас.
Можем начинать уже в целом.
Окей?
Ограничений нет.
Hello. Good afternoon, dear colleagues, dear guests. First of all, I would like to welcome all the participants of our webinar. I would like to thank all the colleagues who have been so kind to give their agreement to participate in this event and to make their presentations. My special gratitude to the co-chairman, the eminent cardiologist and endovascular surgeon, and my personal friend, Professor Andris Erglis.
Thank you very much.
I hope you all know the program, but let me present it to your attention once again without comments. So, I suggest to proceed as follows. I shall open our meeting now, and I would ask Professor Erglis to summarize and make conclusion at the end of the webinar. This first. Also, I would suggest to ask your questions after the hearing of all four presentations. And finally, please remember that after our webinar, all the participants will receive 2 links by email. This will be the links for the feedback form and for the evaluation form. You need to answer the questions and to fill out the evaluation form and send them back to the organizers. After that, you will receive your certificates. So, if there are no other suggestions, let us start with the first presentation entitled, What is COVID-19? I shall share some necessary information concerning COVID-19, which will help us to discuss the issue related to the treatment of cardiovascular disease during this pandemic. So, first slide. No, it's not first. Excuse me, but some problems, technical problems. So, a novel outbreak termed coronavirus disease 2019, COVID-19, has continued to challenge the healthcare system globally. By the middle of July 2020, approximately 12 million positive cases of COVID-19 were in the world, with approximately 545,000 deaths. Excuse me, the technical problems with changing the slides. So, COVID-19 is the disease caused by an infection of the SARS-CoV-2 virus, which belongs to the family of viruses called coronavirus. It also includes the viruses causing the common cold and the viruses causing more serious infections such as severe acute respiratory syndrome, SARS-CoV, and Middle East respiratory syndrome, MERS-CoV. The median incubation period is estimated to be 5 days. Almost all patients who have been infected will develop symptoms within from 2 to 14 days. SARS-CoV-2 virus primarily causes respiratory tract infections, and the severity of the COVID-19 disease can range from mild to fatal. Serious illness from the infection is caused by the onset of pneumonia and acute respiratory distress syndrome, ARDS. How is transmission of this disease? The SARS-CoV-2 virus is thought to spread from person to person via droplet transmission, aerosol transmission, contact transmission, and direct transmission. What kind of risk factors there is in COVID-19? The elderly and patients with pre-existing medical conditions have a higher risk of dying from the disease. Smokers, including those who may use e-cigarettes or vaping, are at much higher risk of developing serious respiratory infections. Next. People with type A blood may be more susceptible to the novel coronavirus, COVID-19. People over 65 years, people living in a nursing home or long-term care facility, people who are immunocompromised, including those receiving cancer treatment, and people with AIDS. What kind of prevention there is? Very easy. Wash your hands. Avoid contact with others who are sick. Avoid touching your mouth, nose, eyes, or face. Cough and sneeze into a tissue or into your elbow. About face mask. Face mask will not protect you from COVID-19 directly, but can help in reminding you to avoid touching your face and will help prevent the spread of the disease to others. Social distancing is recommended. It means the physical separation of people. First, stay at least 2 meters from other people. Don't gather in groups. Stay out of crowded places and avoid mass gathering. About symptoms. What symptoms are mostly in this disease? The most common symptoms of COVID-19 include dry cough, fever, and shortness of breath. Losing your sense of smell and taste is an early sign of COVID-19. The new data allow to add 6 new symptoms to the list of COVID-19. Chills, repeated shaking with chills, muscle pain, headache, sore throat, and new loss of taste or smell. You can see in a long and large list of drugs which are used in treatment of COVID. But I have not so many time to talking about from each of these drugs. I would like to say only that there are no FDA proud treatment for COVID-19, and because I would like only show you this list of drugs. Overall risk in hospitalized patient is low, with a pooled incidence rate of 3%. This risk increased to 19% when patients are admitted to the intensive care unit. Again, some problems with. And now I would like to say some words about the complications most often found in COVID-19. First is the coagulopathy. Coagulopathy is COVID-19 has a thrombotic character. It is increasingly accepted that hyperinflammatory state, cytokine storms, and hyperviscosity seen in a subset of COVID-19 patients leads to increased thrombotic complications. Venous thromboembolism has been reported from 20 to 85% of patients with severe COVID-19 in the intensive care unit, and may be associated with poor prognosis. Patients may be predisposed to venous thromboembolism due to the direct effect of COVID-19 or the indirect effect of infection. Patients with very high D-dimer levels have the greatest risk of thrombosis and may benefit from active monitoring. Thromboembolic events in COVID patients are common and may be unsuspected at the time of death. A autopsy study revealed deep vein thrombosis in approximately 16% of patients in whom venous thromboembolism was not suspected before death. The studies highlight the importance of having a high suspicion for venous thromboembolism in patients who have signs of coagulopathy, including elevated D-dimer level. While these patients are at higher risk of thrombotic events, they may also be at an elevated risk of bleeding, and the bleeding is in approximately 11% of cases. This slide, I would like to show you the picture of a virus that damaged endothelial cells, causing a clotting disorder that can lead to deep vein thrombosis and pulmonary emboli. This picture was possible to getting more after more autopsy reports on COVID-19 patients, and it was very helping. Next complication, and also very dangerous complication, is stroke incidence. Patients with COVID-19 have a relatively low rate of imaging confirmed stroke, but a far greater rate of cryptogenic stroke than that seen both historically and in contemporary cohort, not known to be infected. COVID-19 causes more strokes, especially in younger patients, and in some cases, stroke is actually the presenting symptom of infection. On the other hand, hospital avoidance by patients experiencing acute cardiovascular problems, including myocardial infarction and stroke, has also proven to be a devastating consequence of stay-at-home orders. Excuse me. Next complication is pulmonary embolism. The pathogenesis of COVID-19 pulmonary disease involves binding of SARS-CoV-2 virus to ACE2 receptors of pneumocytes and endothelial cells, leading to development of acute lung injury. A high incidence, around 15% of asymptomatic deep vein thrombosis, was reported in a cohort of patients with COVID-19 pneumonia. The autopsy data clarified that severe endothelial injury in the COVID-19 lungs leads to clotting disorder in the capillaries of the lungs, as well as widespread thrombosis with microangiopathy. The high rate of deaths causing pulmonary embolism at autopsy correlates well with the unsuccessful resuscitation in these patients. Pathologists describe the lungs of these patients as congested and heavy. While a normal postmortem combined lung weight averages around 500.5 grams for men and 600.5 grams for women, the COVID-19 patients had a mean combined lung weight of around 2 kilograms. Massive pulmonary embolism arising from thrombi located in the deep veins of the lower extremities or in the prostatic venous plexus was the cause of death. Other findings included elevated levels of lactate dehydrogenase, D-dimer, and C-reactive protein. Procalcitonin immunoassays were mostly negative. This data helped dispel the idea that all COVID-19 deaths are clear-cut acute respiratory distress syndrome and reinforces the suspicion that Thrombotic events are an important feature of this disease. It's not just the pulmonary syndrome, it's a multi-organ dysfunction syndrome, which is in part manifested by disease of blood vessel and venous and arterial thrombotic events. Next complication is also very strong and very severe complication, kidney failure. Acute kidney failure is a serious complication of COVID-19. Approximately from 36 to 78% of hospitalized patients develop acute kidney injury. And of this, approximately from 15 to 35% require renal replacement therapy. Nearly 90% of patients on mechanical ventilation developed acute kidney failure, and 97, approximately 100% of patients requiring renal replacement therapy were on ventilators. The death rate for patients with severe acute kidney failure is about 50%. Very high indices of the deaths. The type of acute kidney failure in COVID-19 patients is complex and involves several factors, not typically seen in acute kidney insufficiency patients in the intensive care unit. Those unique factors include possible invasion of the kidneys by the coronavirus and tendency to form blood clots and the formation of active mediators of inflammation. Risk factors of renal insufficiency include age over 65 years, black ethnicity, history of acute kidney injury, chronic kidney disease, cardiovascular disease, hypertension, heart failure, hepatic disease, and diabetes. Causes include hemodynamic changes, hypovolemia, viral infection, leading directly to kidney tubular injury, thrombotic vascular processes, glomerular pathology, or rhabdomyolysis. Cytokine release syndrome. Elevated serum pro-inflammatory cytokines and inflammatory markers have been commonly reported in patients with severe COVID-19. Cytokine release syndrome may cause ARDS or multiple organ dysfunction, which may lead to the deaths. Common features include abdominal pain, other gastrointestinal symptoms, and cardiac inflammation. This syndrome has been temporarily associated with COVID-19 only, and patients may test positive or negative for SARS-CoV-2 with COVID-19. Next complication, also very dangerous and very severe complications, septic shock in COVID patients. Sepsis can be suspected based on acute deterioration in a patient in whom there is clinical evidence of infection. Think, could the sepsis, whenever an acutely unwell person presents with likely infection, even if the temperature is normal? Septic shock has also been redefined as a subset of sepsis in which there is coexistence of persistent hypertension requiring vasopressors to maintain mean arterial pressure more than 65 millimeter, and serum lactate more than 2 millimole. Disseminated intravascular coagulation is a manifestation of coagulation failure and an intermediate link in the development of multi-organ failure. If the risk of shock is high, for recognition, take 2 sets of blood cultures, measure serum lactate on a blood gas, assess the patient's hourly urine output, and give intravenous broad-spectrum antibiotics after taking blood culture if there is evidence of a bacterial infection. Intravenous fluids if there is any signs of circulatory insufficiency, and oxygen if needed. Guidelines for the management of shock in critically ill patients with COVID-19 recommend a conservative fluid strategy, crystalloids preferred alkaloids, and a vasoactive agent. Noradrenaline is the preferred first-line agent, with vasopressin or adrenaline considered suitable alternatives. Dobutamine is recommended in patients who show evidence of persistent hypoperfusion despite adequate fluid loading and the use of vasopressors. Low-dose corticosteroid therapy is recommended for refractory shock. Some words about vascular surgery. I hope that I know that my colleagues will talking about vascular surgery, about heart surgery and heart complication much more. But I would like to say some words about these problems. Vascular surgery in COVID patients is very, very strong problem. Numerous concerns have emerged regarding whether to defer vascular procedures and the protection measures necessary during the treatment of a patient with COVID-19. Deferring elective operations and redefining major hospitals as pandemic hospitals were the main measures taken by authorities. Most of the larger volume cardiovascular centers have become pandemic hospitals and have mainly been treating patients with COVID-19. The availability of the surgical and anesthesia staff, accessibility to the operating room and angiographic suite, and readiness of surgical equipment and supplies are considered of top priority when deciding whether a patient should undergo surgery. In addition to the capacity of the healthcare center, what constitutes an emergency situation should be determined specifically for each surgical specialty. Therefore, was used a concept of level of priority for cardiovascular procedure. I would like to show and would like to say very shortly about this table. Here is 4 degrees. LOP1, the definition of level of priority of vascular surgery, and LOP1 is elective surgery, routine admission for operation. So, LOP2, urgent surgery. Patients not electively admitted for surgery, but who require intervention or surgery during the current admission for medical reasons. This patient cannot be discharged without a definitive procedure. LOP3. LOP2, this is, and LOP3 is next. LOP3, emergency. Operation necessary before beginning of next working day after decision to operate. And finally, LOP4, salvage. Patients requiring cardiopulmonary resuscitation en route to operating room or before induction of anesthesia. And small comments. LOP1 conditions can be delayed to the greatest extent possible. LOP2 to 4 conditions should be considered on an individual patient basis and the availability of the healthcare system. The current situation favors the use of endovascular procedure due to the decline of the operative time in comparison with open surgery and the possibility to use local or regional anesthesia. The latter is preferred because intubation and the use of ventilators are not required. Endovascular procedures could also be beneficial for blood conservation. Physicians must provide care to their patients, which places them at high risk of infection with COVID-19. Personal protective equipment is a key issue for healthcare workers. This equipment for the surgical team should include certain extra equipment compared with the standardized one. A face shield over goggles and mask, a surgical coat, and preferably double gloves fixed with adhesive drapes to the surgical coat are recommended for additional protection during surgery. In conclusion about vascular surgery, the LOP concept could be of value in deciding whether to defer a vascular surgical procedure when performing a vascular surgery, whether endovascular or open, for a patient with suspected or confirmed COVID-19. Full protection should be supplied to the healthcare workers in the operating room and geographic suite. Somewhat about heart in COVID-19. Compared with survivors, those who died were more likely to have elevated troponins as well as comorbidities. In most studies concerning COVID-19, it is noted that myocardial injury in patients with this disease is associated with increased risk of deaths, and that elevations and changes in troponin 1 may be an early warning sign of poor long-term prognosis. 16 or 20, from 16 to 20% COVID-19 patients had evidence of cardiac injury on admission, demonstrated by elevated levels of troponin. Patients who died were significantly more likely to have had myocardial injury than those who survived, 75% versus 10%. On admission, most patients who died presented higher leukocyte count, neutrophil rate, and levels of aspartate transaminase, creatinine, C-reactive protein, and procalcitonin. These patients also were more likely to have elevated levels of creatinine kinase myocardial band, myohemoglobin, and N-terminal pro-B type natriuretic peptide in addition to troponin. Those who died also were older, more often male, and more likely to have a comorbidity such as hypertension, diabetes, coronary artery disease, chronic renal failure, chronic heart disease, or cerebrovascular disease. The most common comorbidity was hypertension. In the period from admission to deaths, cardiac indicators showed a dynamic change in the deaths of a group, especially in the level of CK-MB and cardiac troponin. Patients with acute myocardial injury were 7-10 times more likely to die than those without myocardial injury. The question is of whether troponin should be measured in all patients with COVID-19 or only in those who are most ill. Also important is tracking when in the disease course the elevations in troponin occur, whether they are new elevations for that patient and what is causing them to rise, which can include anything from myocardial infarction to myocarditis, right ventricular strain, and even cytokine storm. Another question is, how many of these patients have depressed cardiac function? We know that not a large number of them have plaque rupture. Some do have a ST elevation, but their proportion is rather low. Imaging could be very helpful in such cases. It's very important to closely monitor changes of myocardial enzymes, cardiac rhythm, and cardiac function, and thus provide timely interventions, especially when using drug against SARS-CoV-2 with potential cardiotoxicity, such as chloroquine and lopinavir and ritonavir. Also, it is premature to say whether these patients are doomed with poor outcomes, since only approximately 30% of individuals died of myocardial injury. However, as elevated markers are associated with cardiovascular comorbidities, cardiac complications can develop to irreversible outcome. Also, there is a possibility that a systemic inflammatory response to pneumonia may set off inflammatory activity in coronary atherosclerotic plaques, leading to their instability and eventual rupture. A lot of questions are without answers. We need to clear up who has new troponin elevations, or old elevations, or chronic elevations. What happens to the infected people who are totally asymptomatic or mildly asymptomatic? Sorry. Do they have elevations? These are the people we need to follow up. What are the long-term consequences in people who don't die? And finally, some words about medical industry in COVID-19 pandemic. Prior to the coronavirus pandemic, the global coronary stent market was worth around 5 billion in 2019 and was set to grow at a compound annual growth rate of 3.4% in the next 10 years to reach over 7 billion. However, in COVID-19 affected regions and countries such as the US and Italy, a decrease in revenues is expected during the pandemic, according to Global Data, a leading data and analytic company. So, excuse me, but again, overall, the COVID-19 pandemic is expected to have minimal impact on life-saving cardiovascular procedures. PCI procedures are considered urgent in treating acute myocardial infarction or a heart attack. However, a proportion of PCI procedures are performed on patients who are not experiencing an acute medical crisis. These non-emergency cases are expected to be avoided or deferred during the pandemic. The ACC and the SCI have recently published a list of consideration for catheterization laboratories during this pandemic. One of these considerations included the avoidance of PCI procedures that can be deemed elective, such as PCI for the stable ischemic heart disease. A proportion of patients with stable heart disease may be treated just as effectively with medication. I am not agree with this position, but naturally medication gives good results, but not so excellent results as endovascular surgery. Additionally, many patients may be hesitant to go to clinics or hospitals for chest pain during the crisis, reducing the rate of diagnosis and treatment of heart disease. Excuse me. Oh. On the other hand, one of the advantages of PCI for patients who require an interventional procedure is its minimally invasive nature and the fact that patients require less hospitalization and reduced recovery time when compared to open heart surgery. This is especially beneficial at the time when maximizing bed availability in hospitals and reducing patient exposure to COVID-19 is paramount. Therefore, PCI may be recommended more often than open heart surgery. I had finished. Thank you very much for your attention. And maybe next, my next presentation is from Professor Andris Erglis. Please, Andris. You know that all questions after 4 presentation.
Okay. I'm not sure. Okay, that's a better. Hopefully. Во-первых, добрый день. Я понимаю, что у нас язык официальный будет английским, и я тогда, как сказать, перейду. Но сейчас я хотел бы поблагодарить Давида Георгиевича, профессора Сальяны, за очень такой... И для меня очень приятно быть вашей частью этого вебинара. And now I will switch to English. And first of all, thank you very much, David, for a fantastic presentation as usual. And this is a really deep and important. And of course, I'm really sorry that I'm a bit nervous because we had how it's usually happening, the Murphy laws, and we had a bit of problem with the left main, but finally everything's done. But now I'm coming back to our management of acute coronary syndrome and cardiovascular disease during the COVID-19 pandemic. And it's of course changed our impression about what we do and how we do. And I don't know how it's in Moscow, in Russia, but at least in Latvia, I will show data, and it's the same in Europe and other countries. And what we've seen that there is a different kind of problems, and maybe for people who are quite long in this business, and it is nothing very new, but on the other hand, it is important. This is my disclosure statement and financial interests. And there I will, of course, you covered this topic, but you know, I need maybe to touch some points and what does mean the infection and the cardiovascular disease. And there is, as you see, there is we know very well, and this is a pathogenetic scheme of association between chronic infections and atherosclerosis. And why it is important, because what we've seen also in our country, that we need to change our impression about how we do, even not for one individual patient, but how we are working on population. And I really see, and I'm looking forward to be in Moscow, and then we will talk about acute coronary syndrome course, which is one of the best what I've seen, or maybe the best course. And this is a question more about systemic points, and it is more about systems, not about disease so much. And as you see here, the various bacteria and viruses have been shown to have a direct effect on the vascular endothelium, as well as indirect effect by systematic cytokines release, both of which contribute to accelerated atherosclerosis. Why I read that? Because this is important. And actually, if you are looking on plaques, then we see very well how different kind of agents are working on those. And it's absolutely nothing new. And we know very well correlation. And I will show you a bit later on about the influenza and mortality. And we talk about chlamydian infection. We talk about so many things. And I remember very well how Ron Waxman actually, how he proposed in 90s to treat atherosclerosis by antibiotics. And this is actually, there is some rationale. And then you see again, for me, it is, I'm really happy. And there's my co-worker and very nice colleague and fantastic Sander Jäger, who always helping me with lectures, and I'd say that I also learned so many other new things. And if we, for example, looking on different kind of infectious agents that have been linked to atherosclerosis disease, and you see there is a cytomegalovirus, chlamydia pneumonia, different HIV, hepatitis, influenza. And you see very well how it's working on lesion formation, activation of endothelium, migration of leukocytes, formation of lipid core, and the same thing, proliferation of smooth muscle cells, rupture and thrombosis. And here you see very well pathogenetic effects. Here you see pathogens. That means that actually coronavirus teach us again to re-evaluate our understanding about coronary artery disease. For example, we went bit back, and this is what we published in our local medical journal, and I'm really happy. And we even with our specialists in infections, we even did common paper 10 more years ago, but you see with every influenza epidemic, you see how also increase mortality rate. That means that actually this is a if you see here, this is a number of deaths. It's in blue. If you see colors, this is the number of deaths of total. Influenza, increased number of deaths. Influenza, again, the months is usually 2-3 months. Again, this is, and also if you look on this yellow line, then you'll see that there is actually, this is a people who are age 65 plus. For example, now in Latvia, this is a very, very high number of people who are older than 65 plus, even 80 plus. We have 85 plus. We have around 7%. That's why, of course, there is a really we need to take count about that. And if you look on monthly deaths from cardiovascular disease and myocardial infarction, again from 2014 to 18, then you see the same picture. Actually, this means that if we have the January, February, December, this is the months is where the epidemics of influenza, and you see how increased mortality rate from cardiovascular diseases, and how increased proportion of patients who died from acute myocardial infarction. And I guess if you will do the same analysis in your country, or it doesn't matter, in Europe, across the globe, we will get the same picture. And that's what it is known. It is nothing very, of course, new, but this is what we need to take account. And for example, if you look here, there is a meta-analysis of 10 case control studies to estimate the association between influenza infection and acute MI. And then you see the recent influenza infection, illness, respiratory tract infection doubles. You can imagine, doubles the risk of acute myocardial infarction. That means that every infection, if you look back and if you remember some slides back, actually could be a very, very serious risk factor. And if you look here on from my perspective, right table, then incidences ratio from acute myocardial infarction after laboratory confirmed influenza, you see days first 3, it is a tremendous increase of acute coronary syndrome or acute MI, and even day 4 to 7. That's what we should again to understand, and this also can explain much better why we have data what we are having for last 3 months again. And for example, this is what we also participate in studies, and then we had a Nordic study and about the influenza vaccination and acute MI. And we can ask why I'm talking so much about influenza, because that's what we know very well. And I'd say that it is the pathogenetic mechanisms are practically the same. And if you look here, then you see, of course, viruses is completely different, but as you've seen, the mechanisms are practically the same. And if you look here, then influenza vaccination and acute MIs, then you see in practically every study, and if you look on meta-analysis, then you see there's significantly associated with corresponding to estimated vaccine effectiveness and around to 30% against MI. That's why we are so looking forward and really looking also for vaccines for maybe even this coronavirus which we are having now. And for example, if you're looking here, a Danish nationwide cohort study, and you see this is published in 2019, it's coming from 2003. And actually this was some 15, 10, 20 years ago, we started to talk about that. And then you look on influenza vaccine and mortality and heart failure, then you see there were all-cause mortality rate. There is a vaccination rate, which was very low at that time. Now they increase very much a vaccination rate. And then you see, of course, we can say also to say that the medicine went forward and other things. But it is not a small number. This is a 134,000 of patients, and you see how went down this mortality rate from heart failure. Vaccination rate, mortality rate. That again, we see a straight direct correlation between those two parts. And the same thing, a Danish nationwide cohort study showed us very well vaccination and all-cause deaths. And then you see vaccination period, and also we really seen that if we do a vaccination even after diagnosis, we also see the really improvement. And which is very important. I guess it is so important for us to understand vaccination time of year and outcome and all-cause deaths. And this is so important to do vaccination in early stage. I mean in September, because usually it started in our part of world in autumn, in fall, in October, November, December, and January. And as you see, if we do vaccination in September, actually the outcomes is much better in comparison with other vaccinations. But I've shown in previous slides that how big impact is vaccination versus no vaccinated patients. And again, here's the 6 cohort study evaluating more than 170,000 patients, and as you see, influenza vaccination patients with heart failure, and there we can see a really decrease of all-cause mortality, heart failure hospitalization, heart failure current hospitalization, and so on. And for example, here we see very well how it looks like in Europe. And as you see, there's, of course, we can speculate for a bit other things, and why it is, for example, we have good data with coronavirus, because I'm a bit afraid that maybe so many patients or people suffered from influenza. But as you see, here is actually the people are vaccinated much often in UK, and you know that actually in Scotland and Ireland also situation is better as well. In England it's close to 70%, and if you look on and Portugal and Spain it is 50%, and then it is a bit less in Italy, Sweden, Denmark, but it's also close to 50%. For example, this is a very rare case. Then Estonia is behind us, even with less vaccinated patients. But if you look here, then we see that there is, I don't know, it seems or not, we have now in year 2019, we have age 65, only 8% in Latvia is vaccinated against influenza, which is for sure not really not enough. Then I will switch from COVID-19 and cardiovascular disease, and what we can say, this is that cardiovascular comorbidities in patients with COVID-19 infections, as you see, then CV comorbidities are common in patients with it is known, but we need to remind that, and also presence of cardiovascular disease is associated with severe illness of COVID-19 infections. This is a very important point, and that's why we will see again. I'm not going to talk and to analyze how we are analyzing mortality, but I guess that there will be very in future interesting things. And also presence on CVD is associated with increased mortality in COVID-19 patients. This is data from, I'm not sure that we can really to go in details in every slide, because this is a busy slides, and also coming from different parts of world, and for example, numbers are not so big, but there's a close to 200 patients, and we put this slide because we know that actually this mother land or a country, for at least how we are counting, is coming from China, and this is also a report from China, comorbidities in patients with COVID-19, and as you see, there is comorbidities, mostly it's hypertension as well as diabetes and coronary heart disease. But as you see, any comorbidities, actually this is around half of patients. And if you look on of prevalence of comorbidities in patients with COVID-19 infections, it's coming from New York, USA. And this is a much bigger study. As you see, it is 5,700 patients, and median age is 63 years. As you see, there's a hypertension is for sure more than half. Obesity, it is 40%, diabetes 33%, 34%, and then coronary artery disease, congestive heart failure, it is a bit less, but also it's a real numbers. And this is an important point. Again, it's coming a meta-analysis of 7 studies. Of course, we have, if we are looking on meantime practice, then the even very big journals are publishing a lot of data, and I'm not sure that we can always, because this is coming so quick and we need to analyze, but of course there is a different qualities and also analysis, but nevertheless we have some impression about that. And if you look on the risk of comorbidities in severe patients compared to non-severe patients, then we see this is a really important, much better. If we have no comorbidities like hypertension, then mortality rate is less in patients with no hypertension, with no diabetes, with no cardiovascular disease and respiratory system disease. And this is actually not, depends on mortality, but actually the illness. This is, sorry, it is not it's not mortality, but illness of COVID. But then you see that actually usually much often suffering people who are really have those 4 comorbidities like hypertension, diabetes, respiratory system disease, and cardiovascular disease. But the same thing if you're looking on higher case fatality rate in patients with comorbidities, and then you see that case fatality rate according to patient characteristics and comorbidities. As you see, of course, this is elderly patients, but this is again very naturally, and we know this is more than 80 plus. I would not to say that this is a very important point. What we are now that actually we should not to look on passport age. We should look on conditions, on mental and physical conditions. But nevertheless, if you look here, that it is quite often goes or come together. But this is very important again, if you look on pre-existing cardiovascular disease and pre-existing diabetes as well as pre-existing hypertension. This is a higher case fatality rate in patients with comorbidities. And also, if you look on this is also published in Lancet. If you look on comorbidities in survivors versus non-survivors, then you see then hypertension, diabetes, coronary heart disease, there's statistical significance higher for non-survivors. Again, you can say that the numbers are not quite big, but doesn't matter. That seems very well, and that's why also the same thing if we are looking on risk factors association with chronic obstructive lung disease, coronary heart disease, and others. Now it is maybe I touch a point, and I will not to go very deep in this, but there was some doubts about angiotensin converting enzyme 2 inhibitor usage, and this is because of course we know very well that the SARS-CoV-2 goes through the angiotensin 2 receptors, and as you see, this is the host receptor through which SARS-CoV enters cells to trigger infections is angiotensin converting enzymes, and also which is a key member of the renin-angiotensin system, or RAS. And there was a really data that maybe it is somehow to usage of inhibitors, AC inhibitors can to provoke a disease. But it is if you will look here about this, there's also some analysis from New York University, and there's a really electronic health records of 12,000, even more than 12,000 patients. And if you look here on medicine, what they use, ACE inhibitors, ARBs, and beta blockers, calcium channel blockers, thiazide diuretics, then you see there is no difference. There's no difference, no statistical difference for patients who use or not to use those kind of medicine. As you see in conclusion, it's also published just now in New England Journal of Medicine, because it was really, there was a discussion, and it was this in papers we discussed here in across the Europe, and there was a different warnings and that all things. But now you see that no substantial increase in the likelihood of a positive test for COVID-19 is association with 5 common classes of antihypertensive medication that we can use this very safely, and we should not discuss anymore about, at least before we will get a new data about this usage. And here you see there's actually again this ACE inhibitors and risk of severe COVID-19, and there you say again the same thing. Why we should look on this cardiovascular manifestation in COVID-19? Because it is not, these mechanisms are not so easy. It's like how it's maybe looks like from first look. And again, this is not my task now to go inside, and go very deep in this. But I will just remind. I will just want to remind that, of course, the manifestations could be acute coronary syndromes, it could be fulminant myocarditis and severe cardiac damage, and this is not only because of acute coronary syndrome, and also it could the viral invasion could cause cardiac myocytes damage directly, and this is what I wanted to say. And this could lead to myocardial dysfunction and contribute to development of arrhythmia. That's why we should again only to remember this, and then for this we again see that there's very playing role, the big role of cytokines. Why it is important? Because it is important, and I'm really looking forward for next speakers how we should treat our patients. And what does mean? Do we really need to, what we should fight? Because we should fight with this, why we are talking about this cytokine storm, why we should talk about devices who can help us to inhibit this cytokine storm, and we should also to this, that the cytokines really directly to influencing this immunomediated injury. That means that we can again to look on myocarditis, and as you see, there's some oxidative stress endothelial dysfunction. That means that we should look on microangulation and different kind of different kind of microangiopathies, and the same thing with endothelial dysfunction and plaque instability, and that's what I shown in our first slide. This is myocardial infarction. And there is also quite interesting analysis of mortality in the myocardial injury in COVID-19, and then you see the mortality of patients with coronavirus disease, with or without cardiovascular disease, and with and without elevated troponin T levels. And then you see that actually the highest mortality rate, which is a really, this means there are patients with cardiovascular disease and plus with elevated troponin. That's why we should be really aware and really to check about our patients. And then also we can, if you look, and that's why it is so important also this previous slide, because it does not mean that it's only patients with cardiovascular disease. Even if for our patients we have elevated troponin level, then it is again, there is a very high risk of mortality. And then it's not so high with cardiovascular disease and no elevated troponin, and the same of course with no cardiovascular disease and not elevated troponin. This is, I guess, it's very important. What we really need, we should very carefully look on troponin levels, and again, we should follow the guidelines and always to take care about troponins. This is coming from Italy and Lombardy, and of course and there's some clinical presentations. STEMI as first COVID-19 manifestation and STEMI during hospitalization, as you see, and there is actually more than STEMI, like first COVID manifestation. There's chest pain and dyspnea and coronary angiography. You see the culprit lesions requiring PCI is 17%, no obstructive cardiovascular disease is 12%, something like that. But you see which is a really high risk is outcomes. If you look on outcomes, then you see that actually the numbers are quite high. This is interesting because we are here in now it's also we have this European White Book, and I guess David also knows that, and we participate and Russia participate there when in Europe, and this is quite interesting to look on numbers, and as you see, of course, this as we see in the population who suffer from COVID is with comorbidities and elderly, but as you see, there is a 12%, which usually is not so high if you look on full population. And for this reason, also ERPCI, I'd say it's very recently gave us advice what to do, and as you see, the allied is usually is very active, and our friends are Darius and so many, and Andreas Baumbach and Stefan Windecker, of course, and as you see, there is a statement or paper how we should look on current opinion of our interventional cardiologists. And this is a ERPC position statement, the management of patients with STEMI. As you see, the maximum delay from STEMI, this is the same. To the perfusion is 2 hours or 120 minutes. But of course, there is something which could be bit to change, and I will to go bit in details on next slides. And as you see, there is a more role now for fibrinolysis, and also if you look here, then if the primary PCI pathways may be delayed during the pandemic, this is important. During the pandemic, due to delays in the delivery of care and the implementation of protective measures, up to 60 minutes. According to multiple experience, I'd say that my experience is that even in no pandemics, if you really can do this also in bit longer period, of course we should always to go for the best, but sometimes best is enemy of good, and this is of course 120 minutes should be a target, but sometimes as you see here, there is a really this interval is now bit to increase. Also, if the target time cannot be met and fibrinolysis is no contraindicated, it should be become the first line therapy. We should again go a bit back, but as I said, it should be again to go for first line therapy in case if it is, of course, there's no contraindications. And also very important points is, and I think this is what we need to really introduce in every hospital. That's at least we from first day also and we started very quick, and that's why maybe Latvia is so lucky. But of course not only because, but at least we also was a chain of this of the part of this chain that all STEMI patients should undergo testing for SARS-CoV-2 as soon as possible. We should not to wait for results, and STEMI patients should be considered potentially a COVID-19 positive. This is a very important point. And also consider immediate complete hospitalization if indicated and appropriate in order to avoid staged procedures. We know that actually in guidelines, usually now we are prefer staged procedures, but as you see here, and in this pandemic period, it's better maybe to go for full revascularization. One thing, and I know that David is now looking, and because it is much more expensive. That means that we should discuss with our authorities, because if we are working on 3 arteries, that means that we are using more stents, more materials, more labor work, and this is so important. That's why they should pay more money for this. It is, of course, at least we need again to discuss this question with our authorities, and also perform a left ventricular angiogram. For me, it was from first look was a bit strange, but this is a very interesting point, and we remember, at least with David, we remember very well. I don't know how you do now, and in past we always did the left angiogram, left ventricular angiogram, and why they are saying, because then you maybe in somehow can to avoid one additional examination with echo. And this is again during pandemic, maybe could be reasonable, because then you are really not to spend the time, you are not spend again the labor, some and so on. Also, in the case of mechanical post-STEMI complications, management should follow current ESC guidelines, taking into account clinical status, accepting the need for triage in time of strict access. So also very important, and this is how we should to protect our not only patients but actually circulating staff and operating staff. And then you see, as I said, that all STEMI patients should undergo testing for SARS-CoV-2 as soon as possible. And as SARS-CoV-2, the test results are not immediately available, any STEMI patient should be considered potentially like COVID-19 positive. That means that individual protection equipment for cardiac health workers of cardiac invasive facilities is suspected or diagnosed COVID-19 patients. And then you see all what we need, then cap and splash, goggles, masks, special masks, which is not only mask, but which is this, at least this protection, this FFP2, this fluid impermeable gown, nitrile gloves, and shoe cover. This is so important for circulating staff, and of course it is even more important for operating staff, and that's what we need to use. And as I said, this is sometimes not so easy. If you look on non-elevated acute coronary syndrome, then you see that I'm a bit looking. I'm talking. So I mean, long lectures that I thought that maybe this time is finishing, but no, I have at least 15 minutes. And if you look on patients with non-STA acute coronary syndrome during COVID pandemic, then you see, of course, if you look on very high risk, that means that hemodynamic instability of cardiogenic shock, recurrent ongoing chest pain, refractory of medical therapy, and life-threatening arrhythmias of cardiac arrest, and acute heart failure, current intermittent ST elevation, there is no doubt. This is for no ST. As we remember, this for STEMI. Now it's for non-STEMI acute coronary syndrome. Then you see that again, we should go to immediate invasive strategy, follow the STEMI pathway. Actually, the same thing is with high risk. There is nothing really changed very much. There is early invasive arterial test result, target less than 24 hours. This is how in old days. Actually, intermediate risk, it is how in old days. It is nothing, people who went through this, they remember very well this high risk, intermediate risk, and low risk. This is the most difficult decision, because one part of those patients goes to low risk, one part goes to high risk. That's why it is usually, we are not talking of intermediate risk, but then you see if there is this established diagnosis of non-STEMI based on cardiac troponins, and at least one of the following: diabetes mellitus or renal insufficiency, left ventricular ejection fraction less than 40, or congestive heart failure, and early post-infarction angina or prior PCI CABG, that of course the test for SARS-CoV-2, transfer to COVID-19 equipped hospital, and then we do non-invasive testing. For low risk, again, test for SARS-CoV-2, non-invasive testing. And there is a ERPCA position of cardiogenic shock. This is management of acute coronary syndrome during the COVID pandemic, but cardiogenic shock. And as you see here, the clinical outcomes in cardiogenic shock is even worse. And that's also, we know why. And again, if you follow carefully, then you understand, and actually you understand why we are in a worse situation. But actually, of course, this is much worse for COVID-19 patients, and as you see, the survival rate is quite unfortunately. We would be nice if we can increase this. And the same thing, the STEMI patients in cardiogenic shock should be transferred and further managed in expert centers. This is important. Again, that's why it says it is so important, the system. It's not only the one expert or operators or doesn't matter, but it is very important, the system, how it's organized. And the patient should be transferred to the expert centers, which may offer a different choice of management cardiogenic shock. Now, I like very much that actually it's coming back, the balloon pump therapy coming back. This is, I never believed that it doesn't work, and I'm really, that's what we discussed also in Moscow course. I'm not so happy with current guidelines, but it is very good that it's coming back, and maybe an option in hemodynamically depressed COVID-19 patients presenting with STEMI and mechanical complication. Also, of course, and then I hope so, and not I hope so, but I know that Dr. Delbiska will talk, and other guys, and maybe Sergey, which is very good friend of mine and fantastic operator and very great person told and there. But this is so important also to go for more usage of ECMO. Of course, we need again bit to wait some evidence, because actually evidence is not so, I'd say, enough for ECMO usage, but at least that is a consideration, and also it is in this paper. As well as we can use impeller, as I said, impeller or balloon pump may be used for manage a left ventricle over destination in patients receiving ECMO. This is also now actually this will be the proposal, because the Tony Gershlik from Leicester now is organizing Horizon, and I would be very happy if your institution also will participate in this study. I will come later on with proposal, but this is a really interesting, again, the European study, which will try to prove the ECMO significance. And here you see the strategical categorization of coronary interventions during COVID-19 pandemic. As I see this, of course, it really depends on clinical condition, ischemic heart disease, and emergent to do, which we can not to postpone the STEMI, non-STEMI acute coronary syndrome in very high risk and high risk patients, of course, the cardiogenic shock, then this urgent, and you see very well what is there written, and there is a lower priority, and of course elective, maybe we can postpone more than 3 months. That means that all our very nice friends, CT interventionalists, know should be to wait, and maybe it's not the right time now to go for CT interventions or for patients with angina class 2 or only newer classification NIHA 2 symptoms. Now we are covering the point where those for patients, those who are left behind in the pandemic, and as you see, there is a COVID-19 situation in WHO European region. There's a very different, as you see, there's a really different colors, and there is a, you see there's a total cases and 40-day incidents, and of course it's changing, and you know very well and how it is, and this is if you want to analyze, and now it's on July 7 and Central European time 10, but of course it's changing every hour. And if someone wants to go deeper, then they can do. But if you look here, then you see, then it is how it's in. We are really happy because in Baltics and in Poland, it's not so high rate as well as in Finland and Norway, for example. Sweden did a bit worse. But there is again, we will see. It's, I guess we should count all as in Latvian saying this. Chickens we are counting in autumn. We will see which strategy will works better. And also, if you look on cardiovascular disease in Europe, then you see that each year each year cardiovascular diseases causes 4 million deaths in Europe. Yeah, and cardiovascular disease account for 45% of all deaths in Europe. That means that actually practically half died and dying from cardiovascular disease. It's the same thing if you look on incidence. This is again 11 million new cases in Europe, and prevalence is around 85 million people are living with cardiovascular disease in Europe. And this is I have no data what does they mean about the Europe and about the whole numbers, but at least 85 million, it is around I guess more than 10%. And now we are looking and now look on those data: 4 million deaths and 85 million people are living with cardiovascular deaths. And now look on what mean is COVID, and there is less than 3 million. And actually, if you look here, there's 200 million deaths from COVID. That means that actually compare 4 million deaths from cardiovascular disease, compare now with 200 million, 200 not million, but 200,000 or 0.2 million deaths from COVID. Of course, if you compare this, then that we can say that COVID, of course, it is a really important thing, but we should not to forget that. We should not get the cardiovascular disease, and that's what we fight sometimes very, with blood, because the people and authorities usually forgetting that, because we should not to put all efforts only on COVID. We should not to forget also cardiovascular disease. That's why this is a bit provocative slide, and Sanders usually likes this: how many millions of people are left behind. We are concentrated now only on COVID, but what's happening with people who are suffering from cardiovascular disease? And then you see there is a lower priority. There's a people perform within 3 months advanced coronary artery disease and angina, class 3 or NIHA 3, stage PCA or non-infarct related artery STEMI. Those patients proximal LED PCI, and as well as CTO interventions and others. That's why it is, again, we need always to balance, to understand. We should not do only to help for patients with COVID, but also to not forget the cardiovascular disease patients. And that's what we see here. It is coming from effects of COVID-19 on healthcare provision for patients with chronic cardiovascular disease. And if you look on outpatients visits, this is coming from Humanities Hospital Milan, Italy. It is 2020 versus 2019. Then you see that January, February, practically the same. Even more. As you see, there was in January, February, this outpatient visit increase. But if you look March and April, it's really dropped. It's really dropped. That means that actually there's no more outpatient visit. What's happening? Who will take care about this cardiovascular disease with patients with cardiovascular disease, as well as diagnostic tests? For example, transthoracic echocardiograms and stress ECG. If you look here, there's practically no one. If it is done in this hospital 600 in April 2019, then in April it's only 2 cases, or in March from 700 to 100. You see, this is a tremendous impact. There's again the tremendous impact on patients. That means that we are not now to taking care about our patients, and this is I guess this is a very bad point. And if you look if you look on reduction of hospitalization for myocardial infarction, again in Italy, because you know that Italy was one of the most tragic this points, at least in March, and this is multi-center observational nationwide survey. And if you see here that admission of myocardial infarction during COVID-19 pandemic in Italy, it's decreased by 50%.
Yes.
The STEMI decrease. Do you hear me?
Here, everybody hear you.
Ah, thank you very much. And STEMI patients decreased by 26%, non-STEMI 65%. How we can imagine where the patients are where they are? Looks like that actually they're afraid and not come to hospital. That means that death rate could increase not only because of COVID, but increase because we are not taking care about our patients. And this is what we should analyze very, very careful, and we should really to look forward how to deal with that. Again, increased mortality in myocardial infarctions in Italy in the COVID-19 era. Then you see a case fatality rate for acute myocardial infarction. It's increased practically 4 times higher mortality if you look on and this is now coming from really important publication, European Heart Journal from the ROSA. And the same thing with STEMI patients. It's again 3-fold higher. But it's like again in days where we had no possibilities to go for revascularization. I guess it is really corresponding again the system of not our skills, but system of how patients are coming to hospital, what we do with patients, and how often we do revascularization. The same thing is twice higher with for non-STEMI patients. And it is interesting that out of hospital cardiac arrest during the COVID-19 outbreak in Italy, actually the same as you see how it's increased, and this is in Lombardia, and they have very nice, and this also I know from Lombardia, from the sport registry, they have very nice this cardiac arrest registry, and it's really again it's published now in 2020 in April in the New England Journal of Medicine, again, this increase, it's really also with COVID cases also increased this case of cardiac arrest. And there you see the patients and out of hospital cardiac arrest characteristics in 2020 versus 2019. And as you see, which is the etiology of arrest is or medical or trauma decrease, but medical it's increased. The EMS arrival time increase, and as you see, there's a statistically difference. The same in male patients, and you can see that this is a maybe busy table, but it is also we can even to. This is I touch so many topics. Of course, I can't go really in deep in all of them. But if you look on outcomes, for example, deaths in the field, then you see that in 2000 it's statistically significant difference between 2020 2019. Yeah, and it is much more worsening in this year. This is a STEMI presentation and care in the non-COVID-19 epicenters, as you see, and the incidence of late presentation. And this is a pre-COVID and post-COVID. And as you see, of course, in every, it is more than 12 hours or some symptom onset of, and more than 24, more than 48 and 72. Actually, this is a, this is again, we see that the situation it was really bad, and this is in Catheterization Cardiovascular Journal published, and reason for the late presentation, as you see, this is a fear. And then we should remember, one of the reasons is fear, and then we should remember all those anecdotes about the fear, and then sometimes we are killed by fear, not by our enemies. And also believe the symptoms were COVID-19 related, and did not want to burden some, emergency department and other things. That's why we should talk with our population. We should really be in this, and here you also see the percentage of new Q waves of initial ECGs, and as you see, it's much more. Again, this is coming from Cleveland. It's not only in Italy; it's also from different parts of world, and then they are counting very carefully. And for example, in Cleveland, Ohio, where Marco Costa chaired before all this stuff, and in Cleveland, but now he moved again to Brazil. But doesn't matter. If you look here, I know those hospitals, and they have very good this this network and also registry. Then you see the percentage of new Q wave of initial ECG really increased in post-COVID-19 era. The same thing, average initial troponin and average initial left ventricle ejection fraction decrease. You see, all those signals is so important. And again and again, the question: who left behind this in COVID-19 era? And I guess that even we should more to focus on. Okay, I have last 5 minutes. On our profession, and we should not only to talk about infection, but also we should talk about this side effects of infection. And here is the impact of COVID pandemic of cath labs, and you can, if you wish, of course, it will be possible to go through all slides, and this is maybe not so. As I said, I have no so many. No, I have last 5 minutes. That's why I'm touch bit what we are having here in Latvia. This is interesting. The weekly excess mortality by country. Again, it is actually the Sweden had a bit higher this, but now it goes back. The same thing in France, Italy also, and this is very important because, of course, in 2-3 months we had a problem, but now we should again, when the mortality going down, we should more now to focus back to previous life and do more. And if you, for example, look on Latvia, we were really lucky, and we have a bit more than 100,000, I mean, infected people, but the last data is 31 was died, and we really do a lot of tests but this is of course with social distancing and other things, but nevertheless, if you look here, then we see also what is really suffering, and I would not be so, as I said, if you look back, then I would not be so be worried about the young people, because for them it is usually the manifestation is not so bad. But of course, we should more to focus on people with comorbidities and also for elderly. And if you look, for example, here at age and sex distribution of deaths with confirmed COVID-19, this is in Latvia, then you see there's a 67% men and women is less than. And of course, it's also could be because the comorbidities is more often, and cardiovascular disease is more often manifestation for men. Yeah, you see, and this is what I really don't like very much. For example, this is in our institution, how it's happened, and what we, unfortunately, if you look, for example, January, February, then it is the coronary angiograms by month, they increase. We do around usually to 700 to 800 and then more close to 800 angiograms and every month. But and if you look here, then the coronary angiograms really decrease, and now we have in 6 months we have more or less than we did not use. We actually not performed practically 1,000 angiograms. That means that patients left behind. If you look on PCIs, we do around usually we do in our institution 4,500 PCIs. That means 4,500 PCIs a year. But now, for example, in this half in 6 months, there's a patient with no PCIs more than 500. That means that you see there's a huge difference, and we have no big difference in urgent. But if you look on elective, there's a huge difference, because we really to continue to do all those things. That's why we are now we are going back, thanks to God. It was not easy. We discussed with our authorities. It was not easy, but you see, April was the dramatically decreased, but now it's coming back, maybe in May and June. But you see, even in June, we still not to reach data. And this is also, if you see of reduction of acute coronary syndromes, it's also there is reduction. But we really try to keep this, and maybe it is not so big numbers, but nevertheless, and that means that maybe it's the mortality increased by CVD. And this is, for example, this weekly total deaths in Latvia compared to previous 5 years. It's no big, huge difference, but of course we need to really taking care about that. So, ladies and gentlemen, and dear friends, and what I want to say in summary, that first of all, thank you very much for giving me this and offer to go for this lecture. But what I want to say, that patients with cardiovascular risk factors and established cardiovascular disease represent a vulnerable population when suffering from COVID-19. Myocardial injury, as defined as an elevated troponin level, is common among patients hospitalized with COVID-19, and primary PCI remains the perfusion therapy of choice in patients with STEMI, if feasible, within again the same like in previous 120 minutes frame, and performed in facilities approved for the treatment of COVID-19 patients in a safe manner for healthcare providers and other patients. Also, there is an association between cardiovascular disease and COVID-19. The majority of patients who need cardiovascular care or for the management of ischemic heart disease may not be infected with this novel coronavirus. We must ensure access to urgent and non-urgent care and continuity of care if need, also in those who are left behind. Thank you very much. And you know, this is my always this favorite picture of Gioconda, and we need.
Thank you very much, Professor Erglis, for your very impressive and user helpful and a little dramatic presentation. Wonderful.
Because it was not dramatic at all. That only what we need, I need a bit more focus that we need to keep our specialty.
Yeah. I suggest to make a small correction in our program. Maybe we will give possibility to our audience to for questions. Now for our two presentation, the question for our two presentation, and later coffee break, and later second part of our webinar. You agree or not?
I'm always agree with you. You know this very well.
Good. So we start the question. We are open for question. А как вот question? Может быть, надо что-то нажать кому-то?
Андрей, если ты меня слышишь, открой, пожалуйста, включи микрофоны для всех слушателей. Они сейчас будут задавать вопросы.
We need a little time for.
Нужно предложить участникам поднимать руки, тогда мы конкретно будем каждому давать возможность сказать.
So, who want to give a question? Who want to ask the question? Hands up, please. And
Yeah, of course, yeah. Давайте.
hello.
Сейчас не могу. Прям сейчас скажи, я ей передам через 5 минут. Прям 2 минуты.
For such interesting and impressive presentation, Professor Erglis, maybe you have question? Anyone?
I'd like to ask you, yeah, of course I have, and you gave fantastic presentation, and how, you know, you are so experienced, not only cardiologist, but professor in medicine. And is it, for me, would be really interesting and important to understand, do you think that it is something very, very extraordinary, or you're facing with this maybe some years ago with different kind of infections, and you are a big organizer, you was and you are one of the chiefs of Moscow and Russia, I mean, in organizing cardiology, and do you think that that we do something wrong, or how is your personal view on this, and how we organize this I mean help and care for our patients?
This is very interesting question, but I think that there is no one question, one answer,
Yeah,
because
sure.
there is different countries, and in different countries help was different. I can say about our country, I think that it was in our country was not bad help for this patient, but I would like to say other. I think so. What for me is very interesting. Your mind. I think that this virus was not such a simple virus. Maybe it was no. It was my opinion. Maybe it's wrong, but I think that it was in laboratory made virus. What is your opinion about this?
No. Yeah, I get your point. Actually, I would not go to speculate, because, you know, it's so many. I'm also discussed, and then I'm.
It's my personal mind.
I understood, but doesn't matter. If at least what the specialists, I really believe them and I trust them, and what they are saying, that it doesn't matter, even if it is not. Of course, it could be that it is initially be some artificial, and then this maybe somehow to leave a lab and went through the game in nature, and then went through and different kind of mutations. But I'm not so sure that it is so important now. And what at least we've seen, and this is very difficult to say, but I really think that that's why I touch so much the influenza, that it is really depends on our systems, not even about if you treat, you see that actually usually the people are suffering who are with higher comorbidities. That means that what we need really to go for this basic level of medicine. We need really to not only wash our hands, but also to really to discuss with our patients for taking medicine, for coming in the right time to hospital, not to wait for 2 weeks or 3 weeks when the different kind of manifestations, you know, to somehow to go up and so on. And I guess it is the virus is really like provoking factor, but it is not usually, I guess, the main cause of death. This is my point.
Yeah, I agree, but I don't know, agree you with me or not, that it's not regular, it's not simple. No, we have every year, we have epidemic of influenza, yes or no? Yeah, we have, but no, it was, and I would like to say that we have not so many, we have had not so many deaths in other groups of patients, no, in other groups of other influenza. No,
yeah, not so sure, because you never tested. Try to test the same with influenza, and you will get the same result. And I guess this is again, I'm not so sure, because as I said, that's why I showed the data about vaccination. But for example, for populations where vaccination is very low, you can, if you will start to check all patients, there will be the same results, I guess. That's what I'm saying. It is, again, it's speculation. I would not
maybe
my personal opinion. That's why I guess that it is really depends on overall level of culture, medicine, and medicine systems. And I'd say that it's coming from even from maybe Soviet era, that it is really was a fight with different kind of infections, and it is, you know, that's why maybe we suffer less than countries for whom it was a bit not so high experience. And if you look, then it is quite interesting that countries with more social systems, medicine systems, actually this death rate is much lower than in countries with very, I'd say maybe more based on insurance and others. This is interesting, but I guess that we need to wait some time, and the analysis could be done only later on.
But what about United States?
Yeah, but that's what I'm saying, because, for example, how you can involve private hospitals in this system. It was very difficult. Now they do that, of course, but you can imagine. For example, that's why, again, this is with epidemic situation, you know, I would not know to go for some final decision, but in my mind, at least what we've seen, that what we need a social, not socialistic, but social system of healthcare.
Yes.
Because if we not concentrate or focus only on one person or individual health, but we should focus on population health. If we are focusing on population health, we can save this one individual person. If we are focusing on individual person health, we can't save population. That is my impression of medicine, and I guess this virus showed us very well that.
Yeah, I agree that the medical help must be social and effective.
Yeah, no, sure.
Not,
This is I agree. It's not always going together. I catch a point. I catch a point.
Social, but not effective.
Yeah.
It is also possible. Okay.
Yeah, of course.
Other questions, audience. From audience, we haven't question. Maybe there is technical some problems. I don't know. Можно как-то узнать, есть вопросы или позвонить?
Скажет.
We are waiting.
Are there any?
If there is no question, then we are going to coffee break. And Andres, I would like to ask you to continue second part of our webinar. Okay?
Oh, thank you very much. And I really, it's my privilege to ask Dr. Sergey Semitko to go for next lecture, and I'm really looking forward. And
sorry, Andres, sorry, without coffee break, or we will give 10-15 minutes for, it's your choice.
I guess because we can take a coffee here, you know, this is
Water closet.
Water closet, it will be a bit more difficult, but nevertheless, I guess that we will forgive someone who will go for maybe 3 minutes. But if you agree that I guess that we can continue, and I see that Sergey is really ready to talk.
Okay. I agree. Can I start with my presentation, colleagues?
Absolutely.
No. Now we have a coffee break, yes, for 10 minutes.
No.
Or not?
I propose to continue.
Sorry?
I propose to continue now, and if somebody will
Okay.
will take, then yeah.
Okay. You are chairman, and you can.
No. This is only my proposal. We are, yeah. Okay.
Нет, он с самого начала сказал, что...
Well, do you see my presentation?
Absolutely, excellent.
Well, thank you very much, dear colleagues. I would like to say hello, everybody, and thanks for inviting me, first of all, and I'm glad to see you. And I'm afraid that it's hard. It's very hard to me make presentation after these brilliant and fundamental reports from academic Iosiliani and Professor Eglis. So anyway, let me go forward and start. We will talk about treating cardiovascular patient during COVID infection who have elevated long-term severe risks, and post-COVID patient represent a serious problem which has not been studied yet. And we guess that hypercoagulability and extensive systemic inflammatory activity and chronic stress can last for a long time in patient after COVID pneumonia and after quarantine, after chronic stress as well. And I think that it can be reason for dramatic increase for CV disease in the nearest future. And some latest studies demonstrate that patients after coronavirus infection have a lot of de novo hyperlipidemia, hypertension, insulin disorders, and other endocrinopathy and CV problems. All these patients will be in focus of our attention in the nearest future, I suppose. And some words about Moscow situation, about Moscow government and health ministry undertook unprecedented effort starting from March. And we are lucky because big cities in Russia did not face healthcare system collapse, which was major concern. Maybe strict restrictive efforts taken brought quite good result, because, for example, in Moscow, there were 28,000 COVID beds were opened. And so, anyway, it's interesting to know that once pandemic started, the number of STEMI, as we heard from Professor Eglis, and elective patient drop in Europe and United States more than 35%. Despite situation in, for example, in our country. For example, Professor Yakovlev from St. Petersburg reported only about 7.5% decreasing without significant change of acute coronary syndrome mortality rate. It's quite interesting, and we have to look precisely on this result and analyze it very critically and precisely. In our center of interventional cardiology is part of University Clinic Nets. And now we started to work with non-COVID and after COVID recovered CV common patients. And hospitalization in our center start with CT scan for every patient, first of all, and then COVID test. And crucial point, we try to do one patient, one room for decreasing of footprint in hospital, then PCI or surgery, and try to discharge patient on next day for PCI patient, and on the second, third day after CV surgery. So this document represents general guidelines for our work. It provides high quality and detailed information, even if there is not enough of appropriate evidential base for some of the topics in the guidelines. Still, all the provisions are a result of expert consensus. Further, I will speak about something that is of interest to me and deserves more attention. And let me start from telemedicine in COVID era. Always telemedicine has always made me feel the cold breath. It's if telemedicine threw us away to the garbage of history, but we didn't notice when the telemedicine began in fact. And of course, COVID that made it obvious. You can see the prototype of the system like that manufactured in Russia. I will show you, and on the slide and in my hand. It's very simple to use and not expensive system. A patient attached electrode to himself, and this little box transmits it of full body ECG via mobile network to the doctor's smartphone. And if it's necessary, a doctor can come to the patient with portable echo machine, and it means that future has been suddenly reached. Another point is non-invasive single visit exam. While we were discussing about sensibility and specificity on non-invasive diagnostic methods, they have reached beyond a simple picture to measure of the function, as you know. And I'm talking about CT angio and CT FFR. And if according to CT angio, a patient does not have left main or proximal LED problem, or for example, a dominant right coronary disease, then optimal medical treatment is a good appropriate option for them. The next simple question is, does angiography need to be invasive today, especially in COVID time? No, it doesn't already. And currently, all of us are divided into two groups, who make forecast and those who listen to them. So we made a decision to follow the mainstream and find for you some information. 100 years ago, the great fortune teller Edgar Casey said that diagnostic catheters would disappear and only guide catheter would be used instead. All working horses guide wire would be FFR wired. Thus said he. The next question is, which patient should have preferential treatment without delay? If you took into the guidance, our patients are in the red and orange columns. For example, it's aged patient with a severe aortic stenosis and poor prognosis. For example, with STS score more than 8 or Euro score more than 20. Here you can see very simple prognostic score with velocity of 5-chair rises, plus minus cognitive impairment, and hemoglobin level, albumin level. And if this score is 2 or more, the procedure cannot be postponed for patient like that. And starting from March, we have performed 2 balloon valvuloplasty on severe acute aortic stenosis patient of 96 and 87 years old. You can see that on the slide. Both patients were extremely sick and could not be discharged from intensive coronary unit without a procedure. And balloon valvuloplasty without prosthesis, without TAVI, I think it's an acceptable option in COVID era, COVID time, like a bridge to TAVI for the very sick patients. So the same approach to the giant AAA, giant aortic aneurysm, acute aortic syndrome, and critical limb ischemia. Another point is one visit for cath lab for interventional. All of us are sure that each patient is to be seen as potentially suspected for COVID. And if we remember about that about 13% of COVID tests are false negative. Patients should be preferably treated in a negative pressure cath lab, if it's possible, to filter breathing contour, to reduce involved staff, to intubate sick patient before the cath lab, to deep clean the cath lab after each patient, and to keep the second one, if you have that, on standby. According to Dr. Samir Mehta, who said, we have to follow in Chernobyl strategy for PCI. Get in and get out quickly to avoid unnecessary exposure to the staff and to the everybody. If we work in general hospital with multiple suites, you can isolate one cath lab just for suspected COVID-19 cases. If we have only cath lab, only one cath lab, it's key that you prioritize it for life-saving procedure. After primary PCI, for example, in a suspected COVID patient, the lab must be cautiously disinfected, and dedicated protocols are available in each hospital. The next question is, can we discharge our patient on same day or next day after PCI? Yes, we can, because no doubt that same or next day discharge in some non-complicated cases is possible in up to 2/3 patients, even in acute coronary syndrome. As we heard from another presentation, previous one, we can say again that hypercoagulability and extensive systemic inflammatory activity can last for a long time in patient after COVID pneumonia. And that is why we have to do prophylaxis venous thrombotic events during hospital and follow-up time. But we have to remember about bleeding complication, and you can see on the slide intramural big hematomas in the muscles in the patients treated by double antiplatelet therapy and heparin. As you know, there are numerous published articles about stent thrombosis during COVID pneumonia, but here we are going to present you a case of stent thrombosis in a recovered patient during complex left main PCR. Well, it was patient 67 years old male. He was discharged from COVID hospital after COVID pneumonia CT2 on May this year, and 1 month later he was admitted with unstable angina in our hospital. And he had moderate anemia, moderate thrombocytopenia, C-reactive protein was 12, and D-dimer, fibrinogen, procalcitonin were 2 times higher. And he became worse progressively. Patient received loading dose of ticagrelor, and we have performed coronary angiography. And that time, his hemodynamic already was unstable with recurrent chest pain. It was severe double bifurcation left main disease with right coronary artery occlusion. We decided to treat him percutaneously because we had not any choice, and decided to use 3 stents and T-stents technique for left bifurcation lesion and T-stent technique for second bifurcation circumflex and marginal branches. After 3rd stent replacement, we saw some growing thrombosis in the stents. We have checked the ACT level again. It was a target about 300 seconds. We took 2B3 inhibitors, then we performed numerous balloon dilatation and 2 series of manual thrombus. I can't show the next slide. Call me the Boris. Please help me. It's interesting. Something happened. Could you show the next one? Well, after 2B3A inhibitor, and in 10 minutes, the picture was slowly becoming better and better with clinical and angiographic improvement. Patient was discharged on 2nd day after PCI, and we know that he is alive. Well, you can't. Maybe something happened with presentation, but can we continue? Can we go forward anyway? The researchers found that inflammatory proteins which were produced during infection significantly change the function of platelets, making them hyperactive and more prone to form dangerous and potentially deadly blood clots. It's important that it can last for a long time in patient after acute COVID phase, and certainly we have to be ready for it. Then the elective procedures should be scheduled only in symptomatic sick patient under optimal medical treatment. It's time it would seem reasonable to avoid elective procedure on patients with significant comorbidities or whom expected length of stay in the hospital more than 3-5 days. Example of procedure to defer include percutaneous interventional and stable coronary artery disease without left main disease, for stable peripheral disease, for foraminal valley atrial septal defect, etc. the mental and physical safety of staff during this time remain of great importance. The role of the cath lab during COVID-19 remain vital because these patients hold and will hold a high prevalence of cardiovascular disease. So, unfortunately, I can't show you the result of PCI with double bifurcation disease, but anyway, let me thank you very much for everybody, and that's all what I have to show you. Thank you.
Sergey, fantastic. It's really, really nice presentation, and I guess that how you want now to organize. We will go now for questions, or we will wait for next speaker, which will be Svetlana Zubiska, and then we'll talk about.
No, I think so that it will be better to give the next presentation now. And
okay, fine.
Yeah, but I am sorry, Andres, I would like to make a small correction. Professor Semitko said that academician Yoseliani and Professor Erglis. I know that Professor Erglis is the same academician of a Latvian Academy. Yes.
May I say something in Russian? Agorec ta stalas.
I beg so pardon. I beg. It's my fault.
No, come on. I guess we are really. I guess that our strength is in our also webinar. It's because we are. I'm still also doing on hands, and I guess it is so important now that we are really people who are operating, who are facing those patients, and that's why we can talk. And I how to say, it is honor to be with you and Dr. Semitko.
Не дали договорить.
So.
Я его выберу. Я выберу его в академию.
What we will know to do, David Georgievich, what we will know to do?
Next presentation.
Okay, Dr. Semitko, then maybe we can go now for next presentation, and then we will come back to your presentation because I have several questions.
Yes.
Yeah.
Okay.
Нельзя исправить? Что это там было?
Then next presentation will be for very known in our country, Dr. Rotabiska, who is a really chairing now our CCU, who is for many years working with patients with acute coronary syndrome patients, not only with acute coronary syndrome patients, but different kind of and also know very well the job in ambulance service, and that's why, and he's also a lecturer and teacher for many of our young colleagues, and not only young colleagues, but you know, in different stages in age. Please,
Andres, and I would like to say that as I can see, a very beautiful lady also.
Absolutely.
I think so.
Thank you.
Absolutely.
Yeah. Do you hear me? Do you see me?
Very well.
Yeah.
Do you see my presentation?
yeah, everything is good.
Thank you very much for invitation to participate in this very interesting international meeting, and I would like to make little corrections. Firstly, I'm not a professor, and secondly, my presentation's name is a little bit different than we can see in our program. But today I would like to speak about the main topic of my presentation is mechanical circulatory support devices and new technologies for the treatment of patients with myocardial infarction. So I will not speak about COVID. patients, because you hear a lot of very interesting and actual information from Professor Erglis about COVID patients in Latvia, about accidents and mortality and so on. So my presentation will be about the practical things, about patients with cardiogenic shock and methods of treatment. As Professor Erglis is mentioned, my main work is in intensive care unit with patients with acute coronary syndrome. My experience in medicine is rather long, and I worked a lot of years, more than 20 years in emergency service and in intensive care unit. So I think that I can to share this information, with my knowledges, with my experience, with all of audience. So my presentation will be about definition. I would like to remain about definition of cardiogenic shock, and then I will speak about specific MCS options which are in use currently, about short-term devices, long-term devices, and about rather new options in treatment of myocardial infarction. So I think that this information will be actually interesting. However, some of these devices are rather new, and maybe we don't face every day with these options, but probably in future we will use this equipment, and it helps to our patients. So some words about cardiogenic shock and the definitions. The definition, what about I would like to speak, includes some things. It is hypotension more than 30 minutes. It means that the systolic blood pressure is lower than 19 millimeter mercury, and the patient's needs of vasopressor infusion. Then patient has some symptoms or signs of shock, as of tissue hypoperfusion. Very important is oliguria and altered mental status, and as well arterial lactates more than 2 millimole per liter. Of course, it's very important signs of pulmonary congestions, which could be confirmed by clinical examination or X-rays, or also transthoracic echocardiography. And if you know, cause of cardiogenic shock are not only myocardial infarction, but as well there are acute mechanical complications of myocardial infarction, and as well it could be right ventricle failure, or any severe brady or tachyarrhythmia. So if we saw patient who is in cardiogenic shock, of course, first what we think about it is myocardial infarction, and first thing what we start with, it is emergency invasive angiography and the urgent echocardiography. Then we saw evidence of left ventricle dysfunction, And next step, what we have to do, emergency PCI of culprit lesion or emergency cabbage operation if patient needs, if he has severe three artery disease. Then we need to think about fluid therapy, diuretic for patients with lung edema, and it is very crucial, invasive blood pressure monitoring. It could be very good, very well to put in, to insert pulmonary artery catheter for right heart chambers pressure measuring. Of course, there are intravenous inotropes and vasopressors, and if patient has huge edema and he doesn't react to diuretics, we have to start ultrafiltration. If all these things don't help and patient is not stable as well, we have to think about percutaneous or surgical implanted mechanical circulatory support to help in cardiogenic shock patient. What does it mean, mechanical circulatory support? There are devices that provide mechanical assistance for patient who has advanced heart or pulmonary failure to improve adequate tissue and organ perfusion. MSC devices could be temporarily or permanently as bridge to heart transplant or as destination therapy. Yes, as I mean, MCS devices classified depending on length of stay. Short term, it means that device is implanted for the short time, not more than 2 or 3 months, and usually it is percutaneously implanted devices, and long-term devices usually implanted in surgical way. And there are left ventricle assist device or right ventricular assist device or biventricular assist device. So another classification of mechanical circulatory support is by support type, left side, right side, or biventricular. As I said before, percutaneous options could be for patient with left heart failure or right heart failure or both ventricular failure. As I mean, there are possible percutaneous options or surgical options as well. Then MCS devices are classified depending on mechanism of actions, and there are 4 groups of devices. There are contrapulsation pumps, volume displacement pumps, centrifugal pumps, and axial flow pumps. And first of them are contrapulsation pumps. Mechanisms of action are the balloon, which is inserted in aorta, inflation during the diastole, and deflation during of systole. And the result is a reduction in myocardial work, afterload reduction, and the improvement of myocardial oxygen supply. The next mechanism of action is volume displacement, and this pump is created as a chamber that fills and empties cyclically. There is a special mechanism or motor which drives a special pusher plate up and down, this one, and then this space is expanding and compressing cyclically, and it imitates pulsatile, it imitate pumping action of the heart, and this pump produce a pulsatile flow to the circuit. And as a result, we have direct end organ perfusion support, which is our main purpose. Then the next type of MCS is centrifugal devices which work by the centrifugal pump principle. And the main mechanism is a special pump which generate vortex to drive non-pulsatile blood through the circuit. And as well as the main result of this mechanism is direct end organ perfusion, and this is also the main purpose of this mechanism. The next type of MCS, it is axial flow pumps, which could be described as the propeller in the pipe. This mechanism contains a rotating impeller with special blades which curves around a central shaft, and this mechanism creates blood flow from the inflow cannula to the outflow cannula, and usually this blood flow is not pulsatile, but it is axial flow. So the main indications for short-term MCS devices are refractory cardiogenic shock, which is a complication of acute myocardial infarction. Then there are mechanical complications of acute myocardial infarction. Then this method could be used in patients with high-risk percutaneous coronary intervention, and then it could be offered for patients who are undergoing high-risk aortic valve replacement, or the other group of patients with very severe recurrent ventricular dysrhythmias. For example, ventricular fibrillation or ventricular tachycardia. And the main contraindications for all percutaneous mechanical circulatory supports are prolonged CPR with inadequate perfusion. Of course, there could be advanced age and advanced malignancy, known malignancy. It doesn't depend on the localization, existing organ dysfunction, and as well intracranial hemorrhage. and relative contraindications contraindications are contraindication to anticoagulation and the severe peripheral vascular disease, which doesn't allow to put these devices inside the blood vessels. Complications after percutaneous MCS implantation could be systemic, connected with infection and sepsis. Then it could be vascular complication, for example, ischemia due to large diameter of cannula, embolic complications, and sometimes these devices could create severe aortic regurgitation as injury of aortic valve. Yes. So specific devices. Now I have to tell more or less information about specific device, and I will start with intra-aortic balloon pump. We know that this device is used for a very long time, and the first used was in 1967. We all know how it works, and we know that mechanism of action is special balloon inflation, which is placed in aorta, and this balloon usually is placed until arteria subclavia sinistra, and result of this method is an increase in mean arterial pressure, reduction of left ventricle and diastolic volume and diastolic pressure. Those decrease myocardial oxygen demand. The hemodynamic support provided approximately half of liter of blood per minute. Contraindications of this device are severe aortic regurgitation, large abdominal aortic aneurysm, and aortic dissection, of course. And complication could be connected with obstruction of big arteries, and of course injury of aorta with aortic rupture or dissection, maybe complications related to pump catheter. Next, the next device which I would like to tell about, it's tandem heart. First used is in 2004, and it is an excorporeal left atrial to arterial assist device, which it is inserted through transeptal puncture from the right atrium into the left atrium. The mechanism is removing oxygenated blood from the left atrium, and those it reduces left atrial pressure and reduce end diastolic and pressure and volume. And afterload is mildly increased due to the blood flow into the large outflow cannula, which is inserted in femoral artery. In the result, we get increasing in cardiac output, mean arterial pressure, and of course coronary support. And the hemodynamic support in this case is between 3.5 and 5 liters per minute. Sorry. Contraindications for tandem heart device are right-sided heart failure and moderate to severe aortic regurgitation. Complications could be antegrade or retrograde cannula migration. It is possible. Of course, left atrium puncture causing tamponade if we get left atrium wall defect, mechanical defect. Then it could be mechanical injury to the inferior vena cava, and it is possible to create an interarterial shunt after we remove this device. The next device, short-term device, is Impella, relatively new device. The first used was in 2005. The main mechanism is miniature axial flow pump system, which continuously pulls blood flow from the left ventricle into the ascending aorta, and thus cardiac output is increased. The pump is mounted on a catheter that is inserted retrograde via the femoral artery retrogradely to through the aortic valve in the left ventricle. And in the result, we get increased cardiac output and mean arterial pressure and coronary perfusion. In this case, hemodynamic support is between 2.5 and 5 liters per minute. Contraindications for using Impella are left ventricle mural thrombus. We risk to get thrombus movement to the circulation, and it could complicate with stroke, with cerebral infarct. Then one of very important contraindications are aortic valve disorders, and as well abnormalities of the aorta as aneurysm, heavy calcifications, or extreme tortuosity. Recent stroke or transient ischemic attack in the past 3 months. Complications, as I mean, aortic valve injury or insufficiency, heart tamponade due to left ventricle injury, and of course ventricular arrhythmias connected or related with mechanical heart irritation. And now some words about ECMO device. First used was in 1972, and this device is created as an inflow cannula, which is placed in via the femoral vein into the right atrium. Then the outflow cannula is placed in the aorta through the femoral artery. So deoxygenated blood removed from the atrium by an extracorporeal centrifugal pump into a membrane oxygenator for gas exchange, and then oxygenated blood then removed back into the patient via arterial cannula. The result of this device is blood oxygenated and end organ perfusion and as a result it increased perfusion of end organ, and the hemodynamic support in this case is rather big if you compare with another devices. It is between 4 and 7 liters per minute. Contraindications for ECMO are severe aortic regurgitations, and complications could be related with ECMO device. It is systemic gas embolism, thrombosis of the ECMO circuit, and failure of oxygenator. It could be some complications connected with technical problems inserting these ECMO cannulas. Now in this slide you can see about all of these mentioned devices, differences between these devices, mechanism of actions, flow, velocity, cardiac synchrony of stable rhythm, and some very important parameters which characterize all these devices. Some words about long-term devices. There are mechanical circulatory support devices which usually are used in critical cardiogenic shock. There are patients with cardiogenic shock, but their condition is improved after vasopressors infusion, but they have signs of renal or hepatic dysfunction. So we think about support devices implantation in this case as well. Sometimes it could be patients with they are clinically stable, but they need inotrope against infusion as well. So in this case, we concern mechanical support devices as well as in both previous groups. Usually we have to concern using of MCS, long-term MCS in cases if patient needs if he has a very severe heart failure and he needs heart transplantation in future. Sometimes these devices help to stabilize heart failure without transplantation as a bridge to recovery. And sometimes we use these devices as destination therapy. There are some examples of assist devices. For example, it is left ventricle assist device. Of course, we have to ask our cardiac surgeon help to insert these devices. Of course, yes, main mechanism is surgically implanted pump which connect the left atrium or left ventricle to aorta. As a result, the patient has unloading of the left ventricle and augmenting cardiac output, and of course improved end organ perfusions. As a complications, I have to mean about bleeding, thromboembolism, and some infectious complications as well aortic valve insufficiency and right heart failure. Left ventricle assist devices are classified dependently on working mechanism. First generation devices usually are pulsatil flow. Second generations usually are axial flow, and the last generation more new devices usually are work by the continuous flow principle or centrifugal principle. There are rather complicated devices, and of course we have to get more experience for working with them. And I would like to mention that in this case we have to work very closely together with our cardiac surgeons. We have to create heart team, as we say, and our main purpose to help our patients and to make their life more with best quality. Right ventricle assist devices work by the same principle as left ventricle assist device. The complications are the same: bleeding, thromboembolism, and infections. And biventricular assist devices work as left and right ventricular assist devices together. As example, I would like to mean about special assist device which sounds syncardia, or pneumatic total artificial heart. Yes. And very shortly about new devices which are not used so often. I can speak about them only theoretically, because in our center we don't use these devices are very complicated with very complicated structure, and of course it is technically, I suppose it is very complicated technically to insert these devices, but as an example, I would like to mean about some of them. It is Everhard, an open vein hydrodynamic impeller designed with large blood flow gaps, and as a result preserved aortic pulsatility and minimal blood trauma and low likelihood of thrombosis. The next device, HeartMate 3. This device is includes a magnetically suspended impeller that is intended to provide continuous support for a decade with low power consumption. The next device is Impella, which usually percutaneously placed retrograde across the aortic valves in the left ventricle, and outflow cannula is placed in the proximal ascendant aorta. The next device, catheter deployed intra-aortic continuous flow device, which is named as aortic. Then the IVAS balloon, which works in the same principle as intra-aortic balloon contr-pulsator. What we know, it is our I would say usual device, which we use rather often in our practice. Torvad device is different from first generation. It is pulsatile left ventricle assist device. And the next device is Neptune and Bivacor. And about Bivacor, I would like to say a little bit more. It consists of a single magnetically levitated spinning disc, which it positioned between separate right and left ventricle chambers. This feature of a device allows the disc relative axial position to change according to the loading conditions of each ventricle. This design allows for passive flow adaptation with a Frank-Starling-like response and the dynamic control of right-left output balance. As you see, all these devices are created, are designed as rather complicated, and but I suppose that they probably are very effective as artificial heart, and they help to improve heart failure clinic, and of course they improve end organ perfusion, what is our main aim in treating patients of severe heart failure. Then then I would like to show you two devices which are one of the option to help improve heart left ventricle ejection fraction and to treat heart failure. Then the next topic what I would like to speak about a little bit about our clinic and about our job, how we work in our Latvian Center of Cardiology. I would like to mention that we have only 1,097,000 of inhabitants in 2020 in the beginning of this year. We have some big clinic, regional clinic in our country, and only in 4 of them it is possible to perform coronary angiography in case of acute coronary syndrome, and only in 1 of them there is cardiac surgeon support. It is our clinic. It is Paul Stratton Clinical University's hospital, in which we are working. The hospital was established in 1910. It is multi-profile hospital with 31 centers, and there are treated more than 300,000 patients per year. Our Center of Cardiology has cardiac surgery, which includes 2 departments, operating rooms, and ICU department with 15 beds, and cardiology, part of cardiology with 3 departments, cath lab, breathing operating room, and cath lab, and ICU with 12 beds. Previous years, we in our intensive care units were admitted more than 500 STEMI patients, and 62 of them, or 20%, were in cardiogenic shock, and 42 of them died. It is 68%. Then some words about STEMI patients' treatment modalities in previous years. Of course, there are PCI 75%, and if we speak about, if you mean about mechanical circulatory support, there is only intra-aortic balloon pump. We use it in 37% of cases. And the other methods you can see in this slide, how what of modalities of treatment we use usually in this case, and how often we are used it. What about cardiac surgery procedures? There are the data of, in 2019, in the previous year. Cardiac surgery procedures more than 1,000, and vast majority of them were in with extracorporeal circulation support, 95%. ECMO, as you see, we implanted ECMO devices only patients to patients after cardiac surgery. There are 14 during previous year. And if we analyze data during previous 4 years, you see that ECMO implanted patient amount is a little bit decreased in this year, but previous year our cardiac surgeons implanted more than 25 devices and explanted 12 devices. So we use this method only after cardiac surgery now. But now we started participation in a new project, in new trial, which started in January of 2018. This is a new study which is aiming to improve the treatment for patients who is suffering from cardiogenic shock. And this project focuses on early use of ECMO device, which support their heart needs to recover from a severe heart attack. There are a lot of centers in some European countries which are involved in this trial, and Latvia is one of them. Our center is one of 30 centers which participates in this trial. So patients which who will participate in EuroShock trial divided to two groups. One of group receives immediate revascularization, of course, and standard care with vasopressors and inotropic medicine, and the second group will receive PCI, of course, and pharmacological support, and the next step, the next method which we are going to use in this case, early peripheral veno-arterial ECMO. Inclusion criteria are, the main of them are presentation of cardiogenic shock, and there are patients who has acute coronary syndrome, or there are problems with recent implanted stents, acute or subacute stent thrombosis. Of course, patients has symptoms or signs of cardiogenic shocks, and this is a hypotension which don't react to the vasopressors, and signs of pulmonary congestions. Exclusion criteria are, there are a lot of exclusion criteria, and you can see them on this slide. I don't want to read this criteria, you can see. And outcome measures are all-cause mortality at 30 days, and all-cause mortality or admission for heart failure, decompensated heart failure at 12 months. So we only start participation, and we don't recruit. We don't have recruited patient at the moment, but we hope that this trial shows a good result related to using mechanical supporting devices, and in future I think that it helps to our patients to survive and to have better life quality and good better results in the treatment of myocardial infarction and cardiogenic shock. So I would like to finish my presentation, and I'll try to answer to your questions. Thank you for your attention, and we are waiting you in Riga as guests and as colleagues. Thank you for your attention.
Thank you very much. Great. Thanks a lot. And we had a lot of new things. And thank you, Dr. Tobisk. Thank you very much for your presentation. And now, I guess what we should do, David, we should maybe ask some questions, any questions to Sergey. And
I have one comment and one question.
Yeah.
Okay, it is possible.
Yeah, sure.
Yeah. So, dear Svetlana, tell me, I would like to say that when you had show us this slide with bridge, mechanical assistance and bridge, as bridge, I would like to say that it is possible also use as a bridge mechanical assistance in the patient with, for example, a post-infarction interventricular defect and cardiogenic shock, because you know that the surgeons didn't want to operate in acute stage because there is myocard. You know that myocarditis in necrosis, and the results can be And I would like to say that we have experience 20-day count pulsation in patient with acute myocardial infarction, interventricular septal defect, and cardiogenic shock. Later he was operated. Unfortunately, he was died, but such experience we had with. And I would like to say that maybe it's not so that first percutaneous balloon pumping have made I in early 18th in Soviet Union. The first case for percutaneous count pulsation. You know that before percutaneous procedure, there was access was surgical. You know, or you are young, and because
no, we know very well, David. We know that's what we've done. It is unfortunately also we facing at that time in 80s with leg amputations. Because of there was a so big the Frenches, and that's actually, of course, it was completely different time, and
for us it was a big help when they arised percutaneous method.
Absolutely.
But my question is, you have good experience in mechanical assistance devices. What kind of devices prefer you in treatment of patient with cardiogenic shock, in myocardial infarction with cardiogenic shock? What of these devices do you prefer?
May I also be
your personal? Sorry?
May I also be to help to answer?
Yeah.
I guess no. That I say why, because this is a bit. We have one like department and one center, but then this is a bit strange because when in some 5 years ago we discussed in your course this, when it's come the Professor Thiele came with his study that the balloon pump is not always necessary, and necessity for balloon pump is not so high in MI patients. And also, as you've seen, that actually this shocks are, you know, that Latvia, it's quite compact country, and it is quite quick. The patients are coming to hospital, and maybe shocks are always not so deep. But what we've seen we've seen a really decrease of balloon pump, interventions. Then we switch around 8 years or something like that back to Impella. But actually with Impella, this is at least in our hands. We've seen that maybe there's not so big, improvement. And then, of course, for many years we are using, like with surgeons together, this ECMO devices. But this is a bit strange that in reality we have this experience so much actually we transferred then the ECMO patients from our CCU to surgery. But, that's why we need to reestablish this. That's why I'm so happy about what Dr. Tobiska showed us, because we need to reestablish this idea for assist device usage of assist devices. And there is one other thing. If you look on Europe, there is no consensus, at least. I don't know how it's in States, but at least in Europe, I don't know how in Russia, but in Europe, it's for sure no consensus. What kind of devices to use, for example, and if you look now on ECMO in different studies, there is a very, very big variability. And that's why I guess that why Dr. Tobiska also not to put for ECMO for COVID patients, because even in some studies, we see that ECMO doing worse than patients with no ECMO. But I guess there is no randomized studies. This is only because we use like shock. You remember how it was with shock trial. With shock patients, it's very difficult to randomize. And maybe Dr. Tobiska not mention also the cooling device, because we do a lot of cooling. We also participate in cooling device, the studies. But I really think that this ECMO study will show us at least some signals. And also, as you said, the same thing is that the devices are becoming much, much more easy to use and simple, as it was with balloon pump. Yeah. And that's why I guess that maybe we can reburn and establish these assist devices for our patients.
Thank you. And Professor Erglis, I would like to ask you, maybe we can give possibility Dr. Semitko to continue his presentation, because the presentation was interrupted by technical means.
Okay.
It is possible.
Absolutely.
Okay. Yes.
Thank you very much, dear colleagues. But anyway, I have just 3-4 slides, last slide, which were interrupted. So I would like to show you, to make you sure that it was a real case with quite acceptable result, first of all. And let me show the presentation. Okay, that's it. Well, let me add some words about cardiogenic shock and mechanical method of mechanical support. First of all, I would say that cardiogenic shock, it's not uniform condition. It's so different kind of hemodynamics problem. Someone is only heart failure, someone is plus elements of hypovolemia and with some vascular peripheral pressure, and it's very heterogeneous situation. That is why we have to firstly divide the cardiogenic shock for the several parts, and then start from mini invasive method to harder and harder and then analyze it. That is why we have not any consensus about mechanical efforts with that patient. So let me to step back and show you the our case. It was patient 67 years old after COVID infection in 1 month later with unstable angina and unstable hemodynamics problem. You can see that we were using intra-aortic balloon pumping, and then we decided to treat it percutaneously because we had not any choice for that patient. When we put third stents, we saw suddenly growing of huge thrombus in the stents, and we checked the ACT, and it was the target level about 300 seconds, and then we used TB3A inhibitor and numbers of balloon angioplasty and 2 serious manual thromboaspiration, and then we in 10 minutes, about 10 minutes, we accepted improvement, and we finish this patient with quite acceptable result. Look at the picture on the right side of the slide. You can see the final result. We can see elements of thrombus, but without any compromised flow, antegrade flow, quite good. This patient was discharged on the 2nd day after PCI, and he is alive. He is alive. And last question is that world is changing, and we must admit it. And COVID is a catalyst of these changes, and we must change with it. And we lost a lot of our old-fashioned habits, and for example, I believe that in cath lab we will carry out just interventional but not diagnostic procedure in the nearest future. Thank you very much again. That's all.
Okay, thank you so much. Maybe we can now, to if audience have any questions to Dr. Semitko or Dr. Dubiska, and then they can answer. And I have Sergey, the question to you. And I know that you are, I know you for so many years, and I've seen how you work and everything, and it's no doubt for me. But also you are a bit provocative always. And for example, now you mentioned that maybe
that is why we love you. That you are very provocative.
because we are, we both. I understood. I catch your point. Thank you. And but for me, it is, for example, this is the question is in reality, because it sounds very well and sounds very good that we can everything to do now, by distance. I'm not sure that we make. Okay, I will not to say this word, but we cannot make a friendship, a close friendship by distance only. But the same thing is, for example, I will. But you'll catch what I wanted to say. So, and now you are saying that we need now to maybe introduce more telemedicine. And for example, he also says that we should do more, for example, not catheter-based diagnostics, but CT scans. But if you look on CT scan, and I'm also for years we are working on CT scans, and then we know that even with functional, if we even to add the functional analysis like heart flow or other things, that even there we have not to get the results what we having if we use. I mean, these catheters. And do you in reality think, or why you guess that it could now to replace, I understood your points, what you said in COVID era, But do you think that it should be also to continue in this way for the future?
Thank you, Andres.
That's
If you look a little bit back on the results of some study, when we see if patient has not any problem with left main, with proximal LAD, and has some stable angina without big mass ischemia induced by stress, that patient, it's optimal medical treatment, it's appropriate decision for them. And I do believe that we have already now, we have enough information from non-invasive method. First of all, CT, of course, and echo, stress echo, and it's enough for decide send him to the cath lab or not. I do believe.
Yeah, but if you look on ischemia study, which is now, it's also, there's so many people who are saying, okay, ischemia study also says, show you that you cannot send patients with, even if they have a stenosis. But then you see even during the 1 year, you have much more spontaneous MIs. And this is what you are saying. I agree that, and they also exclude patients with left main and proximal LAD. Nevertheless, the first of all symptoms, and second, spontaneous MIs are much often in ischemia study.
It's a different diseases actually, acute coronary syndrome and stable coronary.
No. But I say it is for stable patients. Even for stable patients in ischemia study, after a CT scan, if they will not be sent to lab, actually the spontaneous MIs are higher in this group. How in second?
Well, I can answer, because the patient after cath lab more agree with treatment. They try to accept optimal medical treatment much more often than patient who couldn't send to the cath lab. It's my opinion.
And maybe I ask one more question, which is for me very difficult here in Latvia, because I don't know who performing, and is it enough people who understand really CT scans in your country and in Moscow?
Well,
Can you repeat?
Yeah, no. What I say is that, for example, what I seen, and we are really do, for many years studies even, but the CT scan analysis is not so easy. This is that there is a, even the angio. If you, for example, go for 5 angio specialists, even invasive cardiologists, they will give you 5 different answers about coronary tree. But in my mind, it is really big problem. I don't know how it's in your country. Maybe it's established very well. But actually, there is always a problem with analysis of CT scan.
I think, Andres, that a CT scan is needed, and it is
no doubts.
In screening of patients. When we have a clear diagnosis, and we know, and as we know that the patient has a coronary artery disease, I think CT scan is not necessary. It is possible. It must to perform the direct coronary angiography and all procedure which it is possible to perform.
I like very much. It's always when they are discussing with you, it's always black or white. But I guess it's not so easy. I agree that we need to go this way. I'm not sure that we really to reach a finish in this question. But I agree that we should transfer more. That's why I said about this heart flow and others. But for me, it is why it is interesting, because, for example, if you ask about the new new topics in our common or yours, but of course when you invite me, and I'm really happy to come. For example, also to discuss this CT scan and what we can get from CT scan, because I'm not so sure that we really have even established. It is not only, I guess it's worldwide. In reality, to understand, you know, you see, for example, if you have a very good radiologist and you are behind him or next to him, there is no doubt that you can get a very good answer for a patient. But do you in reality think that in every hospital, in every outpatient, in polyclinics, in every outpatient hospital, you can perform CT scan with good results? This is my question. Sergey.
Well, as you know, our clinic is quite small one, and a lot of the doctors who perform CT scanning, CT angio, catheterize this patient later. It's true, and Professor Yassiliani agree with me because Dr. Arusamian yesterday performed CT scan and then go to the cath lab and perform catheterization. That is why we believe in his result of CT scan, because year by year he compare your result with CT angio and direct catheterization as well. It's depend on.
Yeah, but you are talking about your own experience. But if we are talking about system.
Well, we have to spread this situation for all world, and it doesn't matter how we thinking about it. I believe that non-invasive diagnostic method win the direct catheterization, which will be only for treating. It's just my personal opinion. Maybe it's not just now, just tomorrow, but in the nearest future, in short perspective, in 5 years. Let's come together in 5 years and discuss it again.
Dear colleagues,
years, I believe.
Dear colleagues, don't forget that we must talking about COVID-19.
Oh.
Yes. And next, we must finish.
Yeah, but I guess that this is why rose the question, Dr. Semitko, because this is a of course, if we can do diagnostics outside the hospital, of course, it really helps us to deal with COVID-19. And this is, of course, a point that I agree with that. The only thing is that what I really want to see, we need some, evidence on this. Otherwise, of course, this is only expert view, but we need evidence.
Right. I agree, absolutely.
Okay, guys, I don't know if I can conclude, and I'd say that we had a for me, it was very teaching webinar, and I'm really thankful to Professor Yassiliani and all team and all speakers, and of course, I guess we cover at least this is we got some essence of what we are having now, and Professor Yassiliani cover all aspects of COVID-19 and how it's impact on our job and our daily practice and theoretical part and pathogenetical part. And I'd also try to show something, at least what we are having now, and changes in PCI recommendations. As usual, Sergey Semitko, doctor, and he is a fantastic, interventionalist and thinker and philosopher, I know. And he cover all the practical points, and also I guess there is so many thoughts which we need now to more establish and to more even to prove. And thank you, Dr. Bisky, thank you very much. And if you would put some slides on, this is, of course, it's in reality very connecting with COVID, because in COVID era we've seen that we need more and more different kind of devices. It's not only for coronaries, but also it is for lung and heart-lung support, and this is even for me was surprised that how many devices you showed us, and we need to know to go for studies. And this is a very important point what Dr. Simitko proposed, and this is why we are bit somewhere to stock in this evidence for shock patients, because shock patients are so variable, as you mentioned, and it's also what we've seen from shock trial, which was 20 years old or even more, and for this reason, I guess it is very difficult, of course, to go for randomized studies. Maybe we need to go for more, I mean, registries, but this Euroshock also could answer us something, and this is my proposal to you also to participate in this Euroshock study. There is this horizon, but I will give you all conditions if you would be agree. And I think it's at least for us, this webinar was very, very helpful, and at least as usual, I enjoy very much, and thank you so much. And it was very, I'd say, meaningful, and many things I learned again. And I don't know, maybe Professor Salan, you will say some, David, you will say some words, and then we can finish.
Andres, I would like to say again, thank you so much. And special thanks to Dr. Tabilska. She was a single ladies in our
I guess she likes that very much.
Brutal company.
I would like to say that today evening I would like to drink a couple of vodka or a couple of whiskey for your health. Thank you very much.
Thank you very much. Thank you so much.
Thank you. Bye bye.
Thank you. Bye. Thanks a lot.
Thank you.
Bye.
Ну все. Дринк. Дринк. Слышь? Да.
Уважаемые участники, всем, кто указал свое имя латиницей, будет выслана на почту 2 формы для заполнения. Один из них тест, другая форма оценки вебинара. После их заполнения вам на почту будет выслан сертификат. Всем тем, кто не указал свое имя латиницей, просьба сделать это в чате здесь. Спасибо. dear colleagues, once again, after the webinar, you will receive a 2 evaluation form that you have to fill in order to receive a certificate in the end. Please state your name in English as it is in your passport, so we could write it in your certificate. Thank you so much.